Hello, I'm Tom Hedman, Senior Principal Scientist with Spinal Simplicity. I'm also an adjunct associate professor with the University of Kentucky, and over the past 40 years, my research has focused on spinal biomechanics, mostly in the academic setting, and more recently, I've moved into the commercialization sector due to technology that I came up with. All right, so what is musculoskeletal biomechanics? This is the study of the motions and deformations of load-carrying, motion-constraining tissues. Clinical biomechanics focuses on the analysis and improvement, potentially, of the mechanical behavior of dysfunctional musculoskeletal systems. Within musculoskeletal biomechanics, there's two fundamental regions that we can discuss. Kinematics, the study of the motions of biological tissues, of the implant with these tissues, and then deformable body mechanics, where we're interested in how well the tissues perform under load. And this involves quantification of mechanical properties. So that topic is called mechanical properties of materials and structures. What are we concerned with in the study of kinematics, where we're looking at motions? We really are focused primarily on aberrant motions that are linked to pain. And so if you're thinking spine, you're thinking a lumbar joint, clearly instability of the lumbar intervertebral joint is well known to be connected to pain. The metric that we typically look to is the neutral zone. It's interesting, the instability at the end reaches of motion typically are not correlated with pain. It's the laxity in the neutral position that is associated and correlated through clinical studies with the incidence of back pain. And of course, the person that came up with this metric that we still use today is Dr. Punjabi, that most of us are familiar with him. I certainly knew all about Dr. Punjabi, knew all his work. I had my own personal copy of his book, Punjabi in White, Clinical Biomechanics of the Spine, before I ever met him or saw him. He didn't attend a lot of conferences, and I'm going back to the 80s and the early 90s, and I first saw him at a conference. He wasn't on the podium, but the person on the podium saw him in the back of the audience and called him forward to comment on whatever the topic was at the time, because Dr. Punjabi was in the room. So I just remember him walking down the aisle very majestically, but there was a look about him that I'll never forget. And to give you the idea of what I saw, he was looking like the Einstein of spine, and his hair was in total disarray, more so than Einstein's here in this photograph, and came up, said some very wise words, but that impression I have not forgotten of sort of the Einstein of spinal biomechanics. So anyways, what did he come up with? 2003, he had a paper. If you look at the motion curve of a lumbar intervertebral joint as you go from a neutral standing to full extension and then neutral standing to full flexion, you'll see a curve like the one shown here. And what Punjabi said is, well, to help you understand what this instability, this laxity is all about, imagine we rotate that extension curve around the horizontal axis, and you're going to have something that looks like a bowl. And if you had a ball in a bowl, that's his analogy, the ball and bowl analogy, that ball can move around very freely at the bottom of the bowl, but it takes more energy and more work as it moves up the sides of the bowl. And really the size of the bottom of that bowl is the neutral zone. It's reflective of how unstable or stable the joint is. If you have a very wide neutral zone, there's a lot of laxity, which means there's a lack of constraint in the motion and the neutral part of the motion curve. Whereas appropriately sized neutral zone will be a pain-free disc. So that's the understanding that Punjabi introduced, and we still hold on to today. Now on to mechanical properties of materials. What you see on this curve on the slide is something that I'm very familiar with and I look at quite often, but I understand you may not be as familiar. Imagine you have a piece of tissue, whether it's a ligament or a tendon or the posterior annulus, and you're applying a load to it. At one point it's going to fail, but before that point you can map out the amount of stretch, deformation, strain, that's the horizontal axis, versus how much load you have to apply to achieve that much stretch. And that would be the load or the stress applied to the tissue. So if you take a ligament, this is a very typical curve that you're going to see. And you see that there's different zones here, there's a lot of information that we can pull from a single load to failure test. It's more than strength and stiffness is the point. In fact, if you're thinking about what correlates to pain, it's that neutral zone size that actually correlates to pain. You then have an elastic region, plastic region. Well, what is plastic deformation? Well, so if you load a tissue and you go up through the elastic zone, it'll return to the same length. But if you load beyond that, you won't see a major failure in the tissue, but you will see an elongation that's not recovered. And so here's the slide I show, the picture I show my biomechanics students for many years to help them get a mental image of what plastic deformation is all about. And here you can see this New Orleans trumpeter has loaded his cheeks and blowing on his horn many times beyond the elastic limit. Now he has permanent deformation of those tissues. So a lot of information on the elastic plastic characterization, but beyond that, we're interested very often in the viscoelastic properties of these tissues, which I don't have time to talk about, but just bear in mind, these tissues are very hydrated, and the water phase influences the mechanical properties as well. Okay, so that's all I'm going to hit high level on spinal biomechanics fundamentals. I want to move a little bit towards how the structures influence the mechanical properties of the tissue. So the tissues itself have properties, the structures have properties. And so we need to understand what these structures look like. And I'm going to start with this schematic of the lumbar disc. If you type into your computer lumbar intervertebral joint or intervertebral disc, you're likely going to see this in 200 places on the web, a diagram, a schematic that looks like this. What's wrong with this characteristic? What's wrong with this schematic? Is that what you have in your mind when you think about the intervertebral disc? Well, it's not right. It's all wrong. There seems to be no definition to the outer annulus. The nucleus covers like 80% of the cross-section of the disc. It's centrally located. This is what a transected disc actually looks like. And what you can see is there is a relatively thin outer annulus layer, which is probably 5 to maybe 8 millimeters thick. Most of the cross-sectional area of the disc is interannulus. And you can see, if you look really carefully, you can see lamella that go in fairly close to the center of the disc, and that's where the nucleus is held. And so if you draw a line around that innermost lamella, then you can see the actual size placement of the nucleus. This is an excerpt from Gray's Anatomy, 35th edition, 1954, describing in general terms what the disc looks like. There's a thin outer zone of collagenous fibers, and I would add dense collagenous fibers. They're connecting bone to bone, and underlying them is a much thicker layer of white fibrocartilage. And then inside of that, the two layers form the disc annulus, and inside of that is the nucleus. So this isn't new. We should know what these structures look like. However, and I want to point out here a landmark paper you're all familiar with, 2001, Furman. Anybody heard of Furman? I remember when I first saw this paper, I felt so bad for Furman's group, and I couldn't believe that this had somehow got through the reviewers in Spine, but it had, and throughout the paper, they mischaracterized the disc. I don't think Furman's group had ever transected a disc or was really that familiar, and so they're misidentifying the structures that they're pointing to. And the statement they have throughout is the distinction between nucleus and annulus is clear. Well, that's not true. It's just not true. And why is it not true? Well, the inner annulus and the nucleus have about the same water content. So a T2 MRI is not going to be able to detect the boundary between the inner annulus and the nucleus. Really what you're seeing is a distinction between the outer annulus and the inner annulus. Fortunate for Furman's legacy, this was corrected in about 5 years later by Griffith et al. They added 3 categories of disc degeneration, and they also got the language right in the tables, on the figures, the distinction between the inner and outer fibers of annulus at the posterior aspect of the disc. If you look at the anterior aspect of a disc, there is not the same distinction between inner and outer annulus, meaning that the inner annulus in the anterior disc is not as highly hydrated as in the posterior disc. So there are subtleties to this structure that are important when you're looking at the mechanical properties of the disc. They're also important, I'm sure, clinically. Other characteristics that influence the mechanics of the disc, I think we're all familiar with the fiber orientation of adjacent lamella in the annulus forming an X shape like the radials on a car tire. This structure produces the mechanical stability of the disc, not just against axial rotation, but against any bending direction. That orientation of fibers, and of course in the inner annulus, those fibers are continuing on into the cartilaginous end plates, forming a capsule around the nucleus. The outer annulus, those fibers are anchoring into bone. So this structure is what produces the stability of the joint. It's also what produces the self-sealing properties, the resistance to expulsion of the nucleus with a healthy annulus. You cannot load a disc high enough to herniate the disc with a healthy annulus. And the way it works is very similar to the Chinese finger trap, right? Someone hands you this little tube, it's made of bamboo or plastic, and you can easily put your fingers in it. You try to pull your fingers out, and the harder you pull, the tighter it squeezes down on your fingers. Same principle with preventing the expulsion of the nucleus with these anchored crossing fibers in the annulus. So the structure brings about the mechanical behavior of the disc that I find interesting and also is important when you're understanding how these things work. Okay, one more statement about how structure influences mechanics is, and again, I hope we're familiar with the hierarchical organization of collagenous tissues, especially any ligament, tendon, posterior annulus. You have this multi-level hierarchy of the structure, and that's what brings about incredible strength for these tissues. Stronger than steel, pound for pound, is true. Ligaments and tendon are stronger than steel. And that's just saying up to that failure point. Beyond that point, steel, you pull on it beyond its failure point, you have 2 pieces of steel, right? You pull on a ligament or a tendon or the annulus beyond its failure point and release it, load it again, load it some more. There's integrity of the tissue that still provides some strength beyond its failure point. So it's an amazing architecture that brings about the mechanical properties of the disc. Okay, let me jump out of this and talk briefly about disc degeneration. The first thing I want us to understand with regard to disc degeneration is what this term is all about. So let me read this quote for you. It has been stated that the term degeneration, as it is commonly applied to the intervertebral disc, covers such a wide variety of clinical, radiologic, and pathologic manifestations as to be really only a symbol of our ignorance. This is a quote from 1977 that was requoted by another seminal article, Modic, in 2007, because it was as relevant in 2007 as it was in 1977. And I would put forth that it's perhaps still relevant to us today, that we merge together a transformation that's going on in these avascular discs over many decades with disc degeneration, with symptomatic or pathologic disc degeneration. And that's a mistake that we do. And I want us to start with this topic understanding that there is a transformation, perhaps even an adaptation going on in the disc from a young, healthy, hydrated, cellular disc and one in your 40s or 50s. Certainly different than the hockey puck disc you have in your 60s, 70s, and 80s, right? So this is an important aspect of disc degeneration. If you want to talk pathological disc degeneration, DDD, we know it has multifactorial etiology in causing it. Genetics has been shown to be very important. You don't have disc degeneration without mechanical overload at some level that then accumulates over time. Nutrient supply starts out bad, and then you have sclerosis of the end plates, calcification. It gets worse. The cellularity declines in its functionality. What cells remain are influenced by the stress intensification of the disc, and so you have this anabolic catabolic balance that gets thrown out of whack. You have certainly the contributions of the neuromuscular tissues around the joint. So it's a complex multifactorial etiology associated with disc degeneration. A couple other just high points here. Disc degeneration begins in adolescence. So really, discs begin to degrade soon after birth with loss of cellularity, and it is accumulating in adolescence. By the time you're in your teens, there is degeneration of the annulus. There is a shortening of the proteoglycan chains. The gags are being lost from the disc, so the water imbibing potential has decreased in your teens. Okay? So not surprisingly, the highest incidence for first incidence of chronic low back pain for men is in their mid-20s to late 20s, and for women it's in their early 30s. And after that point in time, it drops off. However, for these patients, it's the beginning of decades of recurrent or chronic low back pain. Another point that's important that I think most of us know today is that disc degeneration always precedes facet degeneration and other tissue degradation. This has been very well established. Okay, and another fundamental of disc degeneration, disc water content or a decrease of water content is not correlated with back pain. This has been a fact that we've known for a long time, but not one that we have generally accepted. And I just remember when I was working with my clinical colleagues in designing the first North American artificial disc lumbar intervertebral disc prosthesis, they kept wanting to increase disc height because that's the problem, right? Well, no, it's not. A loss of 25% disc height, desiccation of the disc, is not correlated with incidence of back pain. So this is a fact we've known but have a hard time accepting. Similarly, at first glance, this statement doesn't seem true, that incidence of acute disc syndrome begins to decrease in the mid-40s age group. So if you look at the 50s and 60s, there's less of an incidence of acute disc syndromes. I think we understand it better today because we understand about the background transformation of the disc over the decades of life, from a young, healthy, hydrated, cellular, functional disc to a very less mobile disc in your 60s, 70s, and 80s. And even the transformation to the 40s is a very different animal than what you had after birth. And so this graph here is showing us sort of the relationship of these different factors in the disc transformation. Nutrition starts out bad, gets worse. Cellularity is on the decline. You have an increase in fibrosis and the cross-linking between the collagen proteins. And that adds to the strength, adds to the stability of the disc, even while you've lost hydration in the disc. So that's the backdrop. The disc is going through a destabilization followed by a restabilization. And it's really in the middle of this intersection of curves where you have the most mechanical instability, and that's what's overlying this highest incidence of back pain. So this picture was brought together by Jeff Lote at an ORS conference, and I thought this was brilliant. You may think this is complicated. To me, this is simplifies a very complex relationship between natural disc transformation and the degenerative disc disease, pathologic disease that we are trying to treat. So what direction, the next question would be, what direction do we want to go if we're going to have an intervention with these folks that are in the middle of this transitional period, decades of back pain? Do we want to push to the left, rehydrate the nucleus, whether by bits of nucleus materials or with hydrogels or some other way to try to re-inflate the nucleus? But wait a minute, the annulus has also degraded. It's at a different point. Are we putting in air in a degraded flat tire? Or do we want to push to the right? Do we want to follow what the body is doing and just increase the stability of that tissue? Do it quickly instead of over decades. And that brings me to my last slide on disc degeneration. Whilst if you look at the population, the highest incidence drops off after our mid-40s. If you look at patients, you certainly see this progressive disorder that we're all familiar with. The arrow on this curve represents back pain patients, whether it's recurrent back pain or chronic back pain. They are seeing a clinician for their back pain. And we know that even at those early stages, although you can't detect it, there is degradation in the disc and in the mechanics of the joint. The gradation of color in that curve is attempting to sort of show that you can't have a correlation with imaging and the degradation at the early stage. You see more correlated imaging with the degradation at the advanced stages of degeneration. But all the while, you have patients that have degenerative disc pathology. In the early stage disease, we almost exclusively use palliative care techniques. Palliative care goes all the way down the arrow, right, with neuromodulation. We are trying to block the pain. But is that really the best thing to do? Shouldn't we be concerned about tilting this curve or flattening the curve and preventing the progression of this disorder earlier on? We do stop the progression of the disc degeneration with surgical intervention, but for good reason. That's placed at the end of this treatment curve because of cost, because of higher incidence, higher risks, higher incidence of complications, routine use of opioids, and so on. So there is good reason to keep that at the end, but it would be best, wouldn't it, if we could flatten this curve. So that's all I'll say about disc degeneration. Let me move on to topics relevant for spinal simplicity and its products. On the left here, you see a CT radiograph from a paper we published last summer where we looked at 43 patients, 69 treated levels, standalone Minuteman use, real-world patients, and we found a 93% fusion rate. We're going to talk now briefly about AO principles, factors known to promote arthrodesis, and the benefits of spinal fixation will finish us up. All right, so what are these AO principles? Where do they come from? it's important to understand that as late as the late 1940s, bone biology and bone healing was not well understood. And consequently, the fracture fixation surgery was hit and miss at that time, as late as the late 1940s. Then a book came out by a Belgian surgeon, Robert Denis, where he began to address this topic. This book caught the attention of a Swiss surgeon. He gathered his colleagues, his Swiss surgeon colleagues, and they met with Denis and talked about bone healing. And out of this meeting came a foundation, an association that were determined to study and understand what was going on and how they could improve fixation, internal fixation of fractures. Their group was founded in 1958. AO, by the way, stands for the first letters of the name of this group in German. I won't insult you by trying to pronounce it. Their research began a year later in a brand new building in Davos, Switzerland. And they were super productive. Clinical scientists looked at did laboratory research, did clinical research, and came up with 4 principles of fracture fixation, bone healing that are still very relevant today. So these 4 fundamental principles of bone healing, how well do they translate to what we're concerned with, spinal arthrodesis? I think they translate very well. Number 1, fracture reduction to restore the anatomy. We are concerned with appropriate anatomy prior to arthrodesis. We always talk about sagittal balance. We are concerned with indirect decompression with posterior implants that are doing both fixation and creating an indirect decompression. Will the SI Liberty product, by that final tweak of joint compression, do something to improve fracture reduction, or in this case, just orientation across the joint? Principle number 2, fracture fixation to achieve absolute or relative stability. We know this to be essential with creating a consistent and certainly early spinal fusion. If you don't have an instrumented fusion, just have grafts, you can expect pseudoarthrosis 25–30% of the time. We know and understand that you need to have as good of a fixation as possible. This is another paper that we published last summer. This is a biomechanics cadaveric study where we were looking at the stability provided by different constructs. All are 360 constructs, lateral lumbar interbody cage, plus different posterior stabilization systems, bilateral pedicle screws, unilateral facet screws with the lumbar cage. And we also looked at the Minuteman standalone. And so this data that I'm showing is the flexion extension data. The height of those curves represents the amount of motion left in the joint. The intact curve is on the left. And you can see that the Minuteman did very well in comparison to these other structures. And even the standalone Minuteman did about the equivalent of a 360 construct with facet screws, which is pretty amazing. However, it's not surprising if you bear in mind that fusion study where we had 69 levels implanted with the standalone Minuteman, and we found a 93% fusion rate. So we know we are achieving the appropriate amount of stabilization to create a fusion. All right, number 3, AO principle number 3, preservation of the blood supply to the bone and preservation of surrounding soft tissues. Again, this is a principle that is well understood. Bone decortication, getting that bleeding bone, the use of osteoinductive grafts like demineralized bone matrix, the use of MIS procedures can all be useful in protecting, preserving surrounding soft tissues, and making sure that we get the blood to the bone that we require. And then AO principle number 4, They found to be critically important early and safe mobilization, and you're certainly going to achieve that with MIS operating characteristics, the tissue preservation of minimally invasive techniques. So here's a paper we just had published in JPR, and it's an RCT looking at surgical decompression versus the Minuteman for spinal stenosis patients. And if you look at just the surgical parameters here, operating parameters, you'll see that there was a, not surprising, statistically significant improvement in a reduction of blood loss during the procedure, shortening of the time of the procedure. I think these things all contribute to the fact that these patients typically are walking out of the clinic at the end of the day, but not so the surgical decompression patients. So all four of these principles do correlate well. If we look at just all the factors you can think of that are important for promoting fast and consistent arthrodesis, here's a list. We've talked about rigid fixation being crucial. Decortication, whether you get bleeding bone by the tap or by the drill or by the implant itself, doesn't really matter. Osteoinductive grafts are important. Osteoconductive implant surfaces, so the cells are comfortable growing alongside the implant. This is achieved with hydroxyapatite coatings, texturing titanium surfaces, use of different lattices and porosity in the implant. Minimal disturbance of surrounding tissues. This is certainly achieved with a minimally invasive procedure, and these MIS operating techniques preserving the tissue and leading to early mobilization. So certainly in all of these factors that promote arthrodesis, these have been fundamental design features of all the spinal simplicity implants with an understanding of these AO principles. Additional benefits of spinal fixation. So when you look at the 360 constructs, posterior fixation leads to more rapid fusion. This was found in a study by Parisian in 2022. And you also will find a reduction in anterior column subsidence. And a couple of studies have shown this. And the reasons for that, it's clear when you have that fixation point at a distance from the anterior column, it's going to further reduce motions. It's also going to transfer some of the loads through the posterior column away from the anterior column and lead to reduced anterior column subsidence. Fixation with preservation of native motion constraining structures adds to stability. So that's a true statement. I just wonder why we would so readily sacrifice native structures that function in constraining the joint in order to replace their function with a device. You're not going to replace it exactly, and so you've created an alteration there that could potentially be problematic. And then the last point that I'm going to make is an opinion that arthrodesis is going to be generally clinically superior to motion preservation techniques for advanced degeneration. And I think this makes sense. While I was one of the leading figures in motion preservation, first North American artificial disc, tested a lot of the early dynamic devices, but as we were trying to move towards a Charnley revolution in the spine, the realization is that you've got really a different animal here, apples and oranges. Do you really want to, here's the question, do you really want to preserve motion, which means preserving the loading of already degraded tissues? And so I think for that reason, especially for advanced degeneration cases, I think arthrodesis is going to be the better treatment modality. Mid-stage, it depends perhaps on the patient. So with that, let me end here. Thank you for listening to this talk today. I hope it was useful. I hope there were some things that were interesting or valuable to you. And certainly if you have questions, feel free to reach out. Thanks.